kidney disease. So it's a disease, the neglected non-communicable disease. So chronic kidney disease, the neglected non-communicable disease. So I have here Dr. Elliot Tano, our guest speaker, and Dr. Pedita Ochre, and Dr. Emmanuel Adomako. Now let me tell you a bit about them. So Dr. Mrs. Pedita Ochre is a distinguished senior lecturer at the School of Medicine and Dentistry, Kwame Nkrumah University of Science and Technology, and leading nephrologist in Ghana. Now she earned an MBCHB from KNUST and became the first fellow for examination in internal medicine at the Ghana College of Physicians and Surgeons in 2015. Now she currently serves as a nephrology subspecialty lead at the college and is a board member of its internal medicine faculty. Let me tell you about his clinical and academic roles. Now she is the head of the nephrology unit at the Confanochi Teaching Hospital. Of course, she's a senior physician specialist and also an adult nephrologist. Now, her research interest is deeply involved in kidney-related research and is affiliated with the H3 Africa Kidney Disease Network. Her key research areas include acute kidney injury, chronic kidney disease, polycystic kidney disease, and hemodialysis and vascular access. Now, let me tell you a bit about Dr. Elliot Cranton Tano. Now, he is a highly respected senior lecturer at the Department of Medicine at the Kwame Nkrumah University of Science and Technology, Kumasi, and is a consultant nephrologist at CAF, as a Confanochi Teaching Hospital, and his work bridges clinical excellence, academic leadership, and public health advocacy. Now, you hear him all the time on radio and TV. And his professional credentials, he's a fellow of the West African College of Physicians, the fellow of the International Society of Nephrologists, and a senior Atlantic fellow for health equity. That's George Washington University. Now, he's a key investigator in the H3 Africa Kidney Disease Research Network and the co-principal investigator for the May Measurement Month hypertension screening campaign in Ghana. Now, his scholarly output includes over 30 peer-reviewed publications, most of them, of course, on kidney. Let me tell you a bit about Dr. Emmanuel Adomako. And he's a Ghanaian-born nephrologist and assistant professor of medicine at the University of Kansas Medical Center, specializing in nephrology and hypertension. He's earned his MBCHB from KNUST in 2011, followed by a residency training at the Eaglewood Hospital and Medical Center in 2019, and a nephrology fellowship at the University of Texas Southwestern Medical Center in 2022. He's a board certified and passionate about helping patients manage kidney disease through both clinical care and academic research. And of course, his areas include general nephrology, mineral metabolism, including kidney stones and electrolyte physiology. So, ladies and gentlemen, you're welcome.
Thank you.
So, we'll start with Dr. Pedita Ochre. I think we're going to start with you. Say ladies first, so we're going to start with you.
Yes,
rightly so.
No, take us through the functions of the kidney.
Thank you very much. I always sum them into just three basic outlines. We have the excretory function, secretory function, and then synthetic function. Then when you take the excretory functions, the kidney excretes unwanted products. It excretes excess water when there's too much water on the body. Some of the regulatory function, when your blood pressure goes too high, tries to regulate it and bring it to normal. Electrolytes, when they are not at the correct places, the kidney regulates it and makes sure it brings them to normal. So anything, a lot of chemicals in the body, when they are not in balance, the kidneys are functioning well, then it tries to regulate them and bring them to the normal set points. Again, the synthetic function, there are some chemicals in the body. Typically, we have erythropoietin that people know of, that kidney produces, that help in producing blood. So basically, I'll just sum up the functions of the kidney into these three categories: regulatory, excretory, and then synthetic.
All right, thank you very much, Dr. Mrs. Pedita Ochre. Now we go to Dr. Elliot Tano. Well, note that Dr. Emmanuel Adomako is online. He's joined us online. But of course, we're having a very big facility here, the e-learning center, so it's going to be a very seamless conversation. Dr. Eletona, tell us about the chronic kidney disease, what we call the CKD.
All right. So when we talk about chronic kidney disease, we are just saying that there is a problem with your kidney, and whatever problem that has been going on with your kidney has been going on for more than 3 months. It happens to be the one that we commonly talk about because more often than not, even when at the starting of, a lot of people don't know. So by the time they get to know or they realize there might be something going on, it might be too late. So the advocacy into why we are worried about the kidney being neglected is the fact that typically people don't discuss the kidneys as much as we discuss other health conditions, the heart, hypertension, diabetes. But over the past recent years, we've tried to push it into the limelight one way or the other. So basically, when we say there's chronic kidney disease, all we are saying is that all the functions which we believe the kidneys do are probably affected. And in terms of timelines, to call it chronic, it should have been going on for more than 3 months.
Wow. Dr. Perito Ochre, tell us about the causes of CKD. What's the causes of CKD?
Causes, we have so many causes of chronic kidney disease. You can group it into the structure of, the kidney has its functional unit called the nephron. And then the nephron has parts. We have the glomerular part, we have the tubular part, we have the interstitium, we have vessels surrounding them. So each of these parts, we have diseases that can affect these various parts. So commonly the glomerular part can have diabetes affecting it. You can have systemic lupus erythematosus, it's a lung disease. You can have even medicines like non-steroidal anti-inflammatory drugs can affect the glomerular part. The tubular parts, you can also have some medicines affecting the tubular parts, and then the interstitium as well. And then you can have even hard medicines like mercury, gold, lead. It can affect the interstitium and the tubular parts. And then the vascular aspects, commonly hypertension, can affect the vessels. So these are some of the causes. But then if I state it in another form, commonly the whole world, we have diabetes being the leading cause, and then hypertension, and we have some chronic diseases that affects the glomerulus called chronic glomerulonephritis, also affecting that. And then we have some genetic diseases like polycystic kidney disease. Basically, these are some of the causes of chronic kidney. But I must say that in Ghana, studies that have been made, some have found chronic glomerulonephritis being the #1 cause in Ghana. Others have also found hypertension, so it swaps, and then followed by diabetes, and then the genetic diseases.
Okay. I'm happy you've elaborated on the causes. But, one of the things that we hear out there is the issue of herbal medicine. Many people are going to tell you that don't take the herbal medicine, because if you take herbal medicine, you're going to get your kidney damaged. You've talked about the causes. I mean, you mentioned steroid stuff. Perhaps you can break it down a bit. Maybe certain key drugs, which are steroids or something like that, perhaps you can chip in. And right. Maybe Dr. Elliott can also talk about this.
Okay, so commonly when we say non-steroidal anti-inflammatory drugs, example is diclofenac, ibuprofen, and our old folk we say abrewabebo, those kind of things. And with paracetamol, when you take it for a long time, it can also damage your kidney. There are a lot of even orthodox medicines that when you take, it can affect the kidney. If you didn't take it the right dose, the right quantity, it can. So it's not only herbal medicine. Herbal medicine, normally we talk about herbal because we don't actually know how it is being processed, what is inside it. So something that you don't know, you cannot talk much about it. We all know that the orthodox one, there are always brochures around it that you can read, no side effects, know what it does. But the issue with the herbs are we don't know much about that. That's why maybe we talk about herbs. As I speak, I cannot pinpoint one herbal medicine that will give you chronic kidney disease in Ghana. I haven't studied into it.
All right. Thanks so much, Dr. Mrs. Perito Ochre. And Doc, if someone has CKD, How are you going to identify the individual? What are the signs? What are the symptoms?
So more often than not, when we are trying to educate the public, one of the very emphatic messages I would always want to carry across is the fact that if we are waiting to find symptoms, then we would be running ourselves into trouble because the symptoms don't come very early, they come very late. Now, what is clear is the fact that chronic kidney disease, when a lot of people get it, it's asymptomatic largely. And in the early phases, when there are a lot of things we can do to correct it, it doesn't show anything. So you and I are sitting, we are going about our activities as if nothing is happening, but the kidneys are eating day by day. So normally I start off by letting people know that, listen, it is without symptoms in the majority of cases. So as you watch us, as you listen, don't say, okay, I don't have all the things Dr. Tanner is coming to talk about, so I don't have it. Then that might be problematic. Because by the time you are getting those things, then it might be a bit too late. So that is the first statement. And normally I would always liken it to, our mobile phones that we use, for instance. I'm sure by now all of us have been making calls, WhatsApp and all. If you don't pick your mobile phone to probably look on to find out what percentage your phone is, you would not know that it's now hanging around 30% or 20% or 50% until the phone runs down to whichever phone you are using. Maybe if it's an iPhone, maybe around 20%, they'll tell you now probably you need to charge your phone. That's exactly how the kidney works. So the kidney would hold the fort until it gets to a place where it probably cannot hold the fort anymore. Then it begins to show the symptoms. So let's not wait for the symptoms. So that's the first part. But nonetheless, there are some things that can show that will let you know there's something going on. So I made the first part emphatic so people don't say, oh, I don't have this, so I won't check my kidney. I would encourage everybody watching, listening, that find time and check your kidneys because, the canker is great. And myself, my colleague, and my colleague online, you realize that it's a global problem, and we'll probably talk about the burden as we get along. So what are some of the things that would let us know the kidney is going amiss? When you pee and you find out that there's froth in your urine or it's foamy, probably there's something going on in your kidney because your urine typically, like, in our local parlance, they say when you pee at a particular spot for a long time, it foams. But probably you are not jonsoing in a particular place, but it's still foaming. And when it foams, it sits, on for a long time. Maybe there might be some protein in the urine. So watch it. And then the other thing is that, are you waking up too many times to pee at night? Now, when you wake up too many times to pee at night, it probably could be maybe from diabetes or from some infection or your prostate that is big and all of that. But evidence has said that nocturia is also another way because your kidney has lost its ability to concentrate your urine, which it cannot hold all through the night, so you have to wake up several times to pee. The other thing is that sometimes if you don't do anything about it and it progresses, you realize that in and around your eye begins to swell. And why that is tricky is the fact that you might see it alone. Because as you wake up in the morning, you are looking in your face in the mirror, you see that in and around your eye is a bit swollen. But by the time you dress up and you are getting to work or you get to work, it is all gone. So, people don't get to see it. So you might ignore it. So please don't ignore those things. And then if you don't do anything about it, your feet also begins to swell when you press a pit. Most people will say, okay, when I sit for a long time, my feet is swelling. But I ask myself, maybe you have been sitting for a long time ever since, but it was not swelling. So how come for the past 2, 3, 6, 1 year, it's beginning to swell? Maybe check your kidneys to find out. The kidney is not the only reason why your feet will swell. Sometimes it swells because your heart has a problem or your liver has a problem, or maybe there's no problem, it's just the veins that probably might have a problem. But if you find these things, please check it. Again, if you are not doing anything about it, with time, as the kidney functions are going down, then, your ability to produce some things in your blood that helps your blood levels to go up. So your blood levels continue to drop without any signal to say that, listen, my blood levels are dropping, let's make more blood. And that is what Dr. Ochiri mentioned, that it's a way that we are able to know the function of the kidney. If your blood levels are going down, you are not bleeding. You are not seeing any blood anywhere. But anytime they go and check your blood level, they tell you your blood levels are low. Please check your kidneys, and it's very, very important. And then again, the one common thing that we are able to know that your kidney is not doing well, especially when you are not too old. I mean, I'm less than 40 years. I'm 28 years. Anytime we are doing screening in my check, when they check my blood pressure, it's a bit high, hypertension. Because we believe that the kidney happens to be the major organ that helps us to control our blood pressure. So if you are too young and your blood pressures are going up, the first question we have to ask ourselves is, how well are my kidneys doing? So that's why we take very interest in checking people's blood pressure, because it's that simple thing that will let us know that just maybe your kidneys might not be doing well. All right. So these are some of the things. Looking forward, sometimes now your urine output is reducing, probably becoming a bit concentrated, or you don't pee as much as you'd want to pee. Looking forward, then if you don't do anything, then now, when things are really getting bad and you are not able to eat, you're having nausea, you're having vomiting, and that is when they report to the hospital and the doctors will say they have malaria. And they will do malaria tests, it's not. So more often than not, by the time we see, they've gone to about 5, 6 hospitals. Somebody is always trying to treat for some malaria, which does not exist. And by the time they get to us, it is late. Now they cannot breathe and they are probably becoming unconscious. And if you don't do anything, then they are dying. So my opening statement, let's not wait for these things, because by the time we wait for them, it will be too late. So the catch message, in case your internet get disconnected and all, please, after listening to us, find time, go check your kidneys. That's what I'm saying.
Thank you very much, Dr. Leotano. I think we'll go online and speak to Dr. Emmanuel Adomako. If he can take us through the how CKD is investigated, and also he can tell us the complications of CKD. Dr. Emmanuel Adomako, if you can hear us.
Sure. Okay. Thank you, sir. So as my senior colleagues outlined, CKD is a very subtle disease. It typically does not show itself until later in the course of the disease. If you are waiting for symptoms to happen, then oftentimes it may be too late in the favor. But first of all, with respect to the investigation, even though it's a subtle disease, like Dr. Tano mentioned, if we are talking about symptoms, one of the earlier symptoms tend to be hypertension. So like he mentioned, a young person with hypertension, it could be that your kidneys could be affected, right? So then it's important to get checked out. In terms of the test, two main tests, blood testing and urine testing. Starting with urine, we test for protein and red blood cells in the urine. These are typically the major manifestations of kidney disease. Other times you can have other manifestations in the urine as well. Now, if there is blood in the urine, I mentioned blood, this may not, often this is not visible to the eye. Right? This is blood that you only perceive under the microscope. So here, other times, especially in kids, you may have blood visible to the eye. When there's protein, the urine it tends to be bubbly, it tends to be frothy, like the frog top of beer, whenever they beer, the frog they have on top. That's how the urine looks like. Then with respect to blood, the things, investigations we look at, two main parameters are urea and creatinine. So these are the measurements by which we assess the kidney function. Now, of course, you are not going to perceive this unless you go to the hospital or you see your doctor and you have these labs. There are other parameters again in blood that we assess, but commonly the urea and creatinine, which we assess to get a sense of what your kidney function is. Then based on this, we do additional workup, including immune testing, serologic evaluation, testing for infections, in order to evaluate the cause of the kidney disease. The third bracket of tests that we do is imaging. And here commonly we do ultrasound. Like Dr. Autry mentioned in her opening statement. Other forms of kidney disease like kidney stones also again may require imaging. Now going on to how it manifests. So we talked about blood pressure being one of the earliest signs. And again, if as the disease progresses, in an analogy, I always compare disorder in the body is found, other your blood count is affected, so patients may begin to swell up. Patients in advanced cases, they may have poor taste in their mouth, food may taste like metal, difficulty breathing, aging. But these are like advanced. By the time you get to this point, then the patient needs dialysis. The earliest manifestations, if you are lucky, might be hypertension, high blood pressure, probably some swelling, anemia. That's if you are lucky. Often patients come to the emergency department, and the first time you are seeing them, the kidneys have been shut down. And they may not have been aware, or they may have received their past magazines, some headache, some elevation in blood pressure, very subtle symptoms. Thank you.
Thank you very much, Dr. Emmanuel Adumako. With these, let's come to Dr. Mrs. Peditortre. Now, let's look at how CKD is treated. Those who come to you with CKD, how are they treated?
Okay, thank you. So when we say CKD, we have stages. Maybe we will go to that, but then we have stages 1 to 5, and then each of them, we have a way of classifying. Then you have to check the urine protein and then check your kidney function and group them and know that this is stage 1, stage 2, stage 3. So for each of them, we have pharmacological and then non-pharmacological. So drug and then non-drug. So basically, the non-pharmacological aspects you may want to depend on the patient presentation. If you have a patient who has come with a complication, maybe fluid overload, normally stage 1 and 2, you may not have those complications though. So for stage 1, you may want to advise the patient on lifestyle modification because the common cause we know is hypertension, diabetes. So we may want to dwell on lifestyle, maybe stop smoking, reduce alcohol, and then exercise. And then if you are obese, you may have to reduce weight. And then based on your risk factor, if it's basically hypertension that has given you the CKD, then we may want to give you drugs to tackle your blood pressure. If it's diabetes, you may want to add medication to tackle it. If you have a lot of lipids or fats in your blood, then we may also have to give you drug in addition. And as you move down, basically from stage 3, 4, that's where the complication sets in. The anemia and the bone disease, the electrolyte imbalances. So we may also do pharmacological and non-pharmacological. Diet may come in to see which ones will affect your electrolytes so that you don't take things. Commonly, your potassium may want to go up because the kidneys, if you are not working well, will not excrete your potassium, it will build up. So we'll look into diet or even drugs that we may have to give you. We'll have to assess that it will not increase your potassium mainly. And then sometimes your phosphate also goes up. So dietary education so that we advise you on what to take and what not to take. And then we add some medication as well. And then when you reach the stage 5 is when people think that it is, when you say you have CKD, people think that your kidneys have failed. Yeah. But there's stages like 1 to 5. It is the 5 that your function has gone so down that your kidneys cannot perform the work that it's supposed to do. So then when you reach the 5, it's still non-pharmacological and pharmacological. And then we may want to, if it's too down, the function is too low, let's say, sometimes even you are in stage 5, but your function is around 15. You say stage 5, the kidney function is less than 15. In between 15 and 10 or even 8, you may still be strong. You may not have much complications. So we can still do pharmacological and non-pharmacological. But then when we see that the functions are so down, you have a lot of complication, a lot of fluid on board, your breathing has become involved, like you can't breathe well, you are swollen and you are confused, drowsy all the time, then we may want to suggest maybe dialysis for you. That is a step in the gap because the ultimate treatment is maybe kidney transplant. But in between that, we may want to start dialysis for you. And Ghana here, commonly we do hemodialysis at the moment, though there's peritoneal dialysis as well. Basically, Confanoche, peritoneal is being done more for children. It's not that it cannot be done for adults. Adults can still have peritoneal dialysis, but basically what we do here is the hemodialysis. So that is it. On top of your medication and the non-pharmacological aspect.
Great. Doc, thanks so much. Dr. Eliot Tano, you've talked a bit about the risk factors. I think you mentioned some. Perhaps you can take us through some of them, and also let us know. For I think she mentioned the issue of your failure of the kidney. People mention kidney failure, and is it the same as CKD, or there are quite some subtle differences? Perhaps you can take it from a bit about the risk factors, and also we can zoom into the differences between the two. I think that will be very proper.
Yeah, sure. Okay, so I'll take that. But I think one of the things that maybe we've not mentioned, which I feel is important, is, we are sitting here talking about kidney disease. Is it really problematic? I mean, I'm sure somebody might be somewhere and say, well, maybe there's nobody in my family, nobody has had kidney disease, so it looks like something that is far off. So for them, they switch to the channel and then they move out. This chronic kidney disease, how common is it? I've not seen anybody with it. So I'll probably just throw some numbers at us, so as to appreciate the numbers. So globally, the world over, what we know, I just counted those of us who are in the studio right now, and we're about 10. So we are looking at global numbers. Chances are that one of us right here in this studio might have form of kidney disease. Well, some will say tafiakwa. I see some of them saying tafiakwa. Not me. Yes, but that's what the statistic is. And that is worrying, and that's why we want you to know so well about your kidney. Because for all you know, you might be the one who might have some kidney damage without your knowledge. But interestingly enough, those are the global numbers when we put everything together. When we descend down to sub-Saharan Africa, or in Africa, for instance, the numbers are even worse than the global numbers. So for some reason, being a black person in itself is a risk of, increases your risk of kidney disease. So if you compare a Caucasian to a black person, being black increases your risk of chronic kidney disease, and that's why we should be mindful of it. What is it in Africa? So about 15.8% of Africans have some form of kidney disease, and that's worrying. We drop to Ghana, as per the data, we have about 13%. So roughly, if we're assuming a population of about 31 million, some 4 million people have chronic kidney disease. So wherever you are, you might be in your office, you might be at home, just look around, and chances are that you probably might have kidney disease. And that's why I want to hammer home the fact that, listen, don't wait for symptoms, especially if you're above 35, 40 years, yearly. Just check your numbers, I call it. Check your blood pressure, check your sugar. And for all you know, you might have kidney disease without your knowledge. So as you watch us, please, after the discussion, don't let it end there. Find a doctor, find a friend who is a doctor, or go to a hospital. And like Dr. Adumako mentioned, the tests to know how well your kidneys are doing are very simple, not too expensive test. It's just urine sample, blood sample, and we'll be able to know how well your kidneys are doing. And then, of course, depending on what we find, we can follow up, with the ultrasound. And again, ultrasound is not too expensive. If you save some mobile credit for 1 month, 2 months, you should be able to do these things. So please, let's do these things because they are important. So why I needed to do this was the fact that when we talk about this, and the numbers I've given you are chronic kidney disease, but I must say that it's not all of them who end up going on dialysis. It's not all of them who would end up, getting kidney failure. There are people who would have chronic kidney disease, and indeed, they will have chronic kidney disease for 30 years, and they are never going to need dialysis. And that is why if you are picked to even have chronic kidney disease, it's not a death sentence. It's not, oh, that's it. But the worrying aspect is not checking and then coming in, like we said, when it is late, when you need it. Because for all you know, it's all a matter of we advising you to drink a lot of water. We advising you to stop that painkiller that you keep taking. Or we advising you to ensure that, if you are not eating well, you eat well, exercise, and simple things. Or maybe you have diabetes, you have hypertension. Ensure that your sugar is controlled. Ensure that your blood pressure is controlled. And if you hear those things, chances are that you can slow your kidney progression down. Thankfully, when we started off, it was such that we had only few medications that prevented people from progressing. Thankfully, now there's a lot of data out there to show that there are medications which we can give you to prolong your life. So if you pick you at stage 3 or something, and we put you on these medications, we can add some extra 15 years, extra 20 years to your life. But if you don't check to know where you are, if you don't get to be seen by a nephrologist or somebody who knows what they are doing, and you feel sick and rather you go to other places and they are giving you more medications that are worsening your plight. Normally, when we talk about medications, Dr. Ochiri mentioned that, well, we might not have a lot of evidence against one particular herbal medication or the other. But mind you, our orthodox medication, which we have done a lot of investigations to know that, listen, if you have, let's say, dysfunction of your kidney, you probably cannot take this medication. Or maybe if I'm giving it to everybody at 2 twice a day or 2 3 times a day, now I know your kidney function is playing around 50%. Because of that, I'll say, no, you cannot take it that way. For you, let's reduce it to once a day or maybe twice a day, not 3 times a day. But we have all these medications that are out there, herbal medications, which they don't consider. Normally, you see, when they do the advert, they'll say, oh, if you are pregnant or you are giving a child, you are breastfeeding, you cannot take it. Then I ask, well, how about those with liver disease? How about those with, 50% kidney function? How about those with 20% kidney function? Can they take it? But they don't even know their kidney function in the first place, and they go ahead to take these medications, which now worsens their kidney function. So by the time they come to us, then things are late. So chronic kidney disease is a whole bracket, right? And then the kidney failure is that segment of people who unfortunately don't take care of themselves well or don't get to be picked early, and then they develop it. And to be honest, when you get there, that is when now the discussion is dialysis. But if you have chronic kidney disease and you're in the early stages, you can live. I mean, I have patients who for the past 10 years, I'm attending to them. They have chronic kidney disease, but they are nowhere near dialysis. In fact, I jokingly tell them that, oh, mommy, most likely maybe you will die from some other condition, maybe stroke, or maybe a car will knock you down, or maybe some cancer or something, and not necessarily the kidney disease, because they are following them up. But if you don't get yourself followed, then you go into that small bracket of needing dialysis, of course, or needing kidney replacement therapy, which now cost issues and like we have it, becomes more burdensome. So our advice to the general public as you listen now is that please get yourself checked. Simple blood test, simple urine test as you watch us. Please get it done so you don't develop kidney failure.
Thank you very much, Dr. Leotano. And let's go to Dr. Emmanuel Adomako to tell us about the kidney transplant, because Dr. Tano just talked about it. So then he can continue. So Dr. Adomako, if you can tell us more about kidney transplant, I'll come back to Dr. Leotano. I think we've had some local interventions. So you can tell us about kidney transplant.
Thank you. So with kidney transplant, that is an option for patients whose kidneys have failed, right, or are very close to failing. Different jurisdictions have different cutoffs of when to start the transplant process. But it goes back to, again, what Dr. Tano said, like seeing a nephrologist earlier. Because if, let's say you have advanced kidney disease, the earlier you make contact with a nephrologist, right, then you can have that goal of achieving kidney transplant and prepare towards it. Because of course it's not patient's kidney transplant don't come off the shelf. That's something you have to prepare for. You need to make sure you'll be able to withstand the surgery. So let me step back a bit. A kidney transplant involves taking kidneys from one individual, because thank God we all have 2 kidneys, and if your kidneys work excellently, then most instances you're able to survive on 1 kidney. The other kidney, thank God for this kidney. So we take it from one individual and give it to another individual. Now there are 2 main issues that always need to be addressed. We need to make sure that the individual that the patient with a kidney disease will be able to withstand the surgery, the major surgery. We need to make sure the heart, the lungs, the rest of the organs are in fine condition for the individual to be able to withstand the surgery, because you don't want to have a successful procedure and the patient dying. Then the other thing is this: because immunosuppression, and type infection also. So again, earlier with the nephrologist is a good thing. Yes, and here again, if your family member, friend has kidney disease, these are the show that assuming your kidney function is excellent, then you may be in a position to be able to donate to the individual. Again, it depends on so many other factors, so many factors I think we could this discussion. I mean,
All right, thank you very much. There have been some local interventions. Perhaps Dr. Towner can take us through with a kidney transplant.
Yeah, so thank you very much. So I think, like it rightly said, I think the idea of transplantation, I think when we mention it, we make it look very big and like some distant thing. But what I say is that just like we've all said, we are saying that if your kidney is not working, just like, the analogy normally I use is you having a faulty car, right? When you have a faulty car, you have two options. Basically, when you go to the mechanic, he tells you, okay, it's the carburetor, or it is the tire, or it is the engine. And normally they'll throw the option at you. Maybe, Mr. Deborah, you need to change your engine. But he'll tell you that, listen, well, if you don't have money to change the engine, we can service it. Okay, so now the analogy here is that dialysis or transplantation is actually the replacing the body part or the car part that is not working and putting in a new one. Excellent. It just begins to work. Okay. But in the body, it is not as simplistic as that, and that's what Dr. Dumako tried to explain, in the sense that we need to let your body be ready for the new product that is coming in. But for the dialysis, what we're actually doing is just like the mechanic will be servicing it. And that's why you realize that when they are just servicing it, you need to be frequenting the place. Virtually every week you are there, every day you are there. Your mechanic's number is the first favorite number because you always run into one trouble or the other. That is what dialysis is. So dialysis is that bridge that helps to service you with the hope that you get a transplant. But unfortunately, in our setting, we make it look like it is just the dialysis. And indeed, there are some patients who have said that, listen, it's just the dialysis they want to do. They will just come, get it done. And even though they have the means and the wherewithal to be able to get transplant done, they just don't want to because of the phobia with it. But I think what we are trying to do now is to let people know that, listen, transplantation is the way to go. Yes, it may have its challenges, but it's still the best. Every nephrologist everywhere in the world will attest that the best form of, modality in terms of kidney failure is kidney transplant. But nonetheless, of course, it has its challenges, which, of course, if you are being seen by a nephrologist, all of those things can be, sorted out. So before then, we used to have transplantation indeed in Kolebu. Kolebu did a lot of transplants, starting in 2006. So transplantation in Ghana is not new, all right? It is not new at all. It's been done from 2006. I think Kolebu had almost about 20 transplants done. Before, I think there was a little fallow period for which there weren't a lot of transplants, because the way it worked was that you get, expatriates to come down with the expertise, and then we put the patients together, and then they will get the transplant done. But over the years, I think for the past 4 or so years, there's been transplantation going on every now and then in Accra. I mean, there are a lot that we don't get to hear of, in the media. And then I think Kumasi, fortunately, we all started ours somewhere last year. So now it's become something that our hope is that it will not become once off. I mean, so we had one set, we've had actually the second set, which again, I think that it was the first set that went into a Bindia frenzy, but the second set that we did was quiet. And we are planning the next set, I think, in the next couple of weeks. So it is something that has come to stay, that we are beginning to let people know that it is not far-fetched. They used to then go to India to get it done, but now we are thinking that, listen, we have a lot of expertise here. Yes, we need still some support one way or the other to hopefully build our expertise. But my hope and prayer is that in the next year or two, virtually everybody in the team should come locally to be able to ensure that we get the best for our patients. Now, cost is always an issue. And I'm happy about the fact that, some 10 years ago, we used to make a lot of noise. Government was not doing anything for our patients, even for dialysis. Thankfully, now government is taking on the cost of some of, the dialysis sessions, which helps. So now, as that has happened, then we can now throw in these options of, listen, government, can you also support some group of patients or who are ready for transplantation? Because the argument we are going to throw to government is the fact that, listen, when you get your patient transplanted, you save money for yourself. Now, you're going to dialyze this patient for, I don't know how long you're going to dialyze this patient. But the moment you take that patient off dialysis after transplantation, then you can get a slot for somebody else who probably will need it. So now that we've begun the conversation, the idea is that with time, and I think we had some meeting with, the select committee for the Mahama Care now, which we have started slipping in the ideas of transplantation. Yes, dialysis they've done well twice a week. We are hoping 3 will be better, but as we do the 3, then we consider the kidney transplantation. So in the field of kidney disease, there's hope. But what I would say is that we don't want you to be discussing dialysis and transplant. We want you to discuss prevention. Help yourself not to get kidney disease in the first place. I think that is the most important thing for me. And that is our take-home message for everybody, that prevent it. If you don't have it, prevent it. If you have it, prevent yourself from getting into kidney failure. And I think if we do that, then of course, then how many people get to kidney failure who will require the dialysis will reduce remarkably. Thank you.
Well, thank you very much, Dr. Leotano. With our topic that we're discussing the fact that chronic kidney disease is a neglected NCD. When we talk about neglect, we're talking about Africa, we're talking about Caribbeans, we have the NTDs. Now, there's a case, Dr. Peditaoche. Why do we consider this? Dr. Leotano is saying that the government is having, there's a bit of intervention here and there, but why do we consider this as a neglected, non-communicable disease?
Thank you very much. I think maybe before later part of last year, that before MPP left the scene, for Ghana, the MPP government brought in the free dialysis 2 sessions, and initially there was some age brackets. But then before that, I think it was only about 20% of our end-stage kidney disease patients who could afford dialysis. So realize about 80% of patients, when they get into that stage, that you tell them that their kidneys have failed, then it's a matter of they just waiting for death to just come and take them. So now for Ghana, I would say there's a bit of hope in terms of the treatment aspect because of the 2 free sessions of dialysis that the Mahama Care has also continued. But then we can still say that it's been neglected for even the whole world globally. When you say the first 10 non-communicable diseases, you don't see chronic kidney disease inside. Meanwhile, when you look at the first 10 causes, we have cancer, we have diabetes, we have hypertension, we have obesity and all those kind of things. And they are the causes of chronic kidney disease. You get it? So chronic kidney disease doesn't feature in the first 10 non-communicable diseases. That when you say non-communicable, it's like it cannot be transmitted from one person to the other, but through some other means you can get. So I think it's still under the roof, and we can let's expose it maybe when we take it in terms of preventive aspects. Everybody that comes to the hospital, maybe free lab tests for everybody. So that because the diagnosis of chronic kidney disease, we said, it's not just one-time thing. You have to get a thing. It should be established that you have had it for the last 3 months. So at least if the government can put in some measures and say that maybe first time everybody do your kidney test, let us know your baseline. So that subsequently when we do and it's going up, you may realize that you may even, when you do the kidney test, your test will fall within the normal range. When you repeat it, you may still be within the normal range, but then it may be going up. You get it? So I think the government should maybe set some system or some strategy so that we can pick it early And like we've all been saying, that early identification is the way to go. So that when we pick people early, the government will end up spending less in terms of dialysis and then transplant issue. If we pick it early, we know national, what is it called? The
Health insurance.
national health insurance. There are a lot of medications that you can get it if you are diabetic. If
The disease. Dr. Admako, can you hear us? So perhaps Dr. Eliotano, if you can take it through. How can we prevent chronic kidney disease?
Yeah. So just maybe on the neglect a bit, why we consider, it was just recently that there was a WHO resolution recognizing chronic kidney disease officially as an entity in itself. When you talk about non-communicable diseases, it was the diabetes, okay, the cardiovascular diseases, in fact, respiratory conditions, and then cancers. In fact, there was no clear WHO guideline that would leave chronic kidney disease as an entity in itself. And normally when you have discussions at the public health level, they will tell you that, it is a complication of the diabetes, right? And we felt that, no, that's neglect. That's what I'm talking about, where you don't see any document to let you feel how important chronic kidney disease is. But meanwhile, kidney diseases, all these complications or all these conditions you talk about, the moment kidney disease gets in, the prognosis, or what we say, your rate of dying increases quickly. If you get diabetes, you are safe until all of a sudden we say your kidneys have a problem. You are dying, right? So the key thing is that we needed to now recognize. And all these years, it was only this year that it was recognized. So it is now that we've made some noise from the International Society of Nephrology with all the, in fact, Guatemala led this, fight, where because they were seeing a lot of young people come with very bad kidney disease, and they were not diabetic, they were not hypertensive and all. And then the world took fire, and now currently, it's recognized. Now we are hoping that this resolution does not sit at the level of WHO now, but comes into the country, like we are saying, that the government begins to recognize. Thankfully, as a country, we've made some progress, so we cannot complain that much. That's what I just wanted to say. On the prevention bit, I don't know whether Dr. Adomako is back or I can just go on. Prevention is key. Prevention is cheaper. Prevention is better. And if everybody or anybody who has watched so far, all have been drumming is the prevention, because that is, for me, the best way to go. In preventing chronic kidney disease, it starts off with, one, where am I in terms of risk? Do I have a family history of diabetes? Do I have a family history of hypertension? Do I have a family history of, there are some genetic conditions which, through no fault of yours, Deborah, you are born into a family. There's a cystic condition in the family, and you are born with it. It's only a matter of time. By the time you become 20 years, boom, you start to get it, right? But if you don't look out for it, you know. So what I say for starters with prevention is, what is my risk? That is what you should ask yourself now. Am I at risk? If you are black, you are at risk. You are greater than 40, you are at risk. You are born into a family with kidney disease, diabetes, hypertension, you are at risk. Oh, you are drinking galamsey water like all of us are drinking, some mercury in there, you are at risk. So the point is that all of us, one way or the other, are at some risk of kidney disease. You are a man, you are growing, all of a sudden your prostate has become bigger. You stand to pee and it's taking you longer. You feel probably you have been standing for too long, so let me hold the rest. With time, it is affecting your kidney. That's risk. A pregnant woman gets pregnant. I mean, through no fault of yours. You just get pregnant. In the course of your pregnancy, your blood pressures go up. That is risk to your kidney, right? So now, there are things that, through no fault of ours, risk. Apart from the ones that, you are taking alcohol, you are smoking. All of these things are risk factors. So assess your risk, and I'm sure all these things I've mentioned, maybe you have picked your own from there. Now, the moment you know your risk, check your kidney function, right? Oh, yes, I have history of diabetes, hypertension. I checked my kidney function today. It's excellent. Okay. Bravo. Let's clap for you. The next 3 months, the next 6 months, the next year, check to ensure it is where it needs to be. That's where it starts from. Then what can I do now to ensure that, I don't get kidney disease? Now, I would ensure that I'm drinking a lot of water. A lot of us, from morning till evening, there are some people who say, where I work, there's no proper washroom. Those market women, they don't have any place to pee. So they don't take a lot of water. And sometimes you don't take a lot of water, you have this knee pain, you go and take diclofenac or brufen or something. all of that is causing, some injury to the kidney. I think one of the things I need to quickly mention as we talk about this is that there are some people who might get an injury to their kidney, right? I'll give an example, at least so people can put it in context. A young man, I mean, he was as slim as you and I, Deborah, and I'm sure probably he wanted to gain some more muscles, right? So let me go to the gym, right? So he tells me the story that, he went to the gym, and the first day he actually met somebody he felt he was a professional. He was like, my brother, this is the first time you're coming. Take it easy. I mean, don't do so much. But the next day he went to the gym, he actually went to meet this guy who I'm sure wanted to create muscles for him overnight. According to him, after that episode, the next day when he urinated, I'll use his words, he was like, Doc, my urine was like honey. Okay? So, and I realized my urine has reduced. So he had a physician assistant friend. He calls him. And he actually had also muscle aches, right? So he calls the physician assistant friend, and he was like, with the muscle aches, and then he prescribes diclofenac for him. Wow. Now my colleague has smiled, because that is double damage, right? Then the interesting bit is that like the muscle aches came down, but he was like, now the urine is not coming at all. Wow. So he calls another colleague of his, who was also a physician assistant. He was like, no, the diclofenac is not good for your kidney. Stop it. And then he changed it to brufen.
Wow.
It is. Now everybody's so interested, but I'll give it to the second physician assistant. He was like, he let him run a kidney function test, and the creatinine, for those who know the numbers, was over 1,000. So he was the one who referred. So when the gentleman came, I was like, listen, this is not chronic kidney disease, because he was referred like, likely you have chronic kidney disease. This is not chronic. There's something we can do something about. So we admitted him, hydrated him, and indeed, as I speak to you now, his kidney function has come to normal. Wow. So there are those ones who might get some insult to their kidney, which when you pick it early, so what am I saying? When you get any condition, please intervention now that will bring him back to the baseline. So reporting early with your condition is very important. And then, of course, I mean, the fact that, listen, whatever condition you have, ensure that you are being seen by a professional. And I mean somebody who knows what they are doing so they can correct it early. Drink a lot of water. In terms of diet, cut down your salt intake. Ghanaians like salt. I'm sure a lot of people like a lot of salt. Salt is linked to hypertension. Hypertension is linked to chronic kidney disease. So let's cut down our salt. Eat a lot of vegetables and fruit, and rather avoid, the high-protein diet and the carbohydrates and the oily foods, because some of these things might end up, giving you diabetes, hypertension, and eventually kidney disease. And then again, like we've mentioned, it is important that you exercise. You are becoming too obese, you are not exercising. I mean, exercising is good. Make sure you are trying to work on your weight. Because listen, I mean, if your weight is supposed to be, say, about 80 kgs, and now you are weighing 120, you are putting so much stress on those small kidneys. Your kidneys are not so big, Deborah. Your kidneys are about the size of your fist, right? So now all of a sudden, if you become very big, it has to still clean this big body. And with time, it also gets
Yes, Dr. Petty
So prevention is better than cure. So we are just saying that know your risk. And for us in Ghana, the number one risk is hypertension, followed by diabetes, and then this chronic diseases, infection that might have gone on in your kidneys that you may not know. So just know your risk and then just go to any hospital, any lab that you want to test your urine, you want to test your kidney function, and then can bring the results to any of us. We are ready to look at it for you and then advise you. Thank you.
Thank you very much. So this the KNUST SMS at 50 Community Impact Series, and there's a collaboration between the E-Learning Center and also the School of Medical Sciences, KNUST. We had wonderful guests here, and that's Dr. Mrs. Petty Torture, Dr. Elliot Tano, and also Dr. Emmanuel Domako. Thank you very much for joining us. Of course, as I said, it's the KNUST at 50 Community Impact Series. We have one on hypertension, and this is on kidney. Have a nice day. My name is Emmanuel Kwesideram. I'm the Digital Communication Officer of KNUST. Bye-bye.
Bye. Thank you.
Oh, God. That's diabetes. Okay, diabetes.